the S2G podcast, where we share conversations that help us understand how to scale the food, agriculture, oceans, and energy transitions. I'm your host, Tanya Bekritzes. In this episode, we take a bite out of the Food is Health opportunity with Matt Walker, Food and Agriculture Managing Director at S2G, and a few of our panelists from the S2G Summit. As a reminder, this content is for informational purposes only. It should not be taken as legal, business, tax, or investment advice, or be used to evaluate any investment or security, and is not directed at any investor or potential investor in any investment vehicle sponsored by S2G. Investing involves risk, including the risk of loss. Specific companies mentioned in this podcast are for educational purposes and should not be construed as an endorsement of any kind. Please note that S2G may maintain investments in some of the companies discussed on this podcast. For more important information, please see s2gventures.com/disclosures. In this episode, we're digging into one of our favorite topics at S2G, food, the way it impacts human health, and the opportunities to develop effective food-based health interventions. In this panel from Summit, Matt Walker, Managing Director at S2G, sat down with Susan Bukata, Professor and Chair of Orthopedic Surgery at the University of San Diego, Bill Dietz, Director of Research and Policy at George Washington University's Global Food Institute, and Howard Lossing, former CEO of Cambrooke Therapeutics, to discuss the Food is Health opportunity. The conversation covered individual versus population health, the shortcomings and positive trends in the adoption of nutrition interventions by the medical community, the data required to back up food-based health solutions, and why our panelists are hopeful about the future of this field. I also interviewed Matt about his reflections on the panel, and we inserted some of that conversation into this episode. So we'll start off with a brief introduction from Matt about why he wanted to focus on this topic at Summit.
This is an area that we've been focusing on for several years now. And at a high level, we are focused on the way that the food that we eat impacts human health. And we see that it plays a critical role in driving human health outcomes at the individual and population level as a whole. And we see that these are two disparate, disconnected systems that are having to pay closer attention to each other. And we recognize more about food's impact on human health. We see a lot of opportunity to improve human health outcomes that is aligned with significant economic opportunity as well. So it's something we're very excited about. We've made several investments in the space, and we will continue to focus on this area.
So let's get into the panel. We'll start with Susan's introduction.
I'm Susan Bukata. I'm the chair of the Orthopedic Surgery Department at UC San Diego. I do oncology, metabolic, bone, and rare bone diseases as a part of my clinical practice, and I do work as a clinician scientist in tissue regeneration in bone mostly. But why I was most interested in all of this is that we get to follow our patients for a long period of time in oncology and people with rare diseases, patients with osteoporosis. And patients come to us, and one of the first things they ask us is, what can I eat? When you diagnose them, what can I have? People are very comfortable with foods and diet in terms of thinking of ways to treat things. We as physicians tend to think about pharma, because that's the way we're trained. You have a disease, we plug in a medication or a treatment for you, you move on, and we're treating to a target. What we've had happen is Google has come around, and people go to Google and they see themselves as the zebra. So when they look at medications, even for diseases where we have very targeted, very effective therapies, everybody sees themselves as the zebra nicely grazing in the fields instead of the herd of horses running off the cliff. And the problem is, from a public health standpoint and from a healthcare standpoint around the world, the herd of horses is mostly what's happening. So how do we think about what patients will embrace in terms of foods and diet as a way of being able to address many of these diseases in a way that people will accept? We have to have multiple tools in our toolbox. How do we look at some of the scientific knowledge that we're gaining to be able to create additional tools that are affordable and accessible to our patients that they will accept and actually make a part of their lifestyle?
and also think about how people are looking at aging and wanting to age well, and thinking about a little bit of preventive medicine in that aspect, because that is what patients are embracing.
Good afternoon. I'm so pleased to be here. I'm Bill Dietz. I'm a pediatrician. I spent 16 years at the Centers for Disease Control and Prevention as the director of the Division of Nutrition, Physical Activity, and Obesity, and subsequently moved to George Washington University, where I directed the Sumner M. Redstone Global Center for Prevention and Wellness. But my most recent responsibility has been as the Director of Research and Policy for the Global Food Institute, started at GW by Jose Andres. And our role there is to, as Jose has said, is to change the world through the power of food. And that's our scope. And that's what I hope we'll speak to today.
My name's Howard Lossing. I've been in medical nutrition for the last 2 decades. Ending in 2023, I was the 9-year CEO of Cambrooke. We were fortunate enough to sell the business to Ajinomoto, who is here. And this business works on therapeutic nutrition for people with chronic health conditions. Prior to that, I was with Danone's Nutricia division, also in medical nutrition, working in the US and Canada and in Europe. That's the resume. I'd like to just offer a perspective that perhaps will give you some thoughts on the color of my commentary. And it's this. If I was a pessimist, I might say the last couple of decades, the pharmaceutical industry has exacerbated the health problems in this country, particularly as it relates to nutrition. And here's the story. My brother, 10 years ago, failed a blood test that said he had high LDL cholesterol. His doctor gave him a statin. 5 years later, my brother was diagnosed as hypertensive. His doctor gave him an ACE inhibitor. Last year, my brother was diagnosed as type 2 diabetic, and now he's on an insulin modulator. No lifestyle change, no diet intervention, and you would think if many years ago he had made a change through nutrition, this cascade of dependency on pharmaceuticals would not be his future, but that's where he is. Now, the optimist, and I'm more of an optimist, I would say that we're at an interesting time, and the door is opening, and nutrition, bioactives, food as medicine, those concepts are finally getting into the toolkit for a comprehensive approach to care for patients. So I look forward to talking more about that. Thank you.
I like the bad news, good news approach that you took there. And perhaps, Bill, if you could do something similar and just give your perspective on the state of play today in population level health.
Sure. The costs of chronic diseases, which are overwhelming, are increasingly driven by obesity and its effect on other kind of comorbidities, such as type 2 diabetes, such as cancer, cardiovascular disease. And the history of the prevalence of obesity is interesting because the prevalence in adults across all age groups was pretty flat until 1975. And in 1975, in parallel, all these populations of different age groups, both men and women, increased in sync. Now, that is an unappreciated aspect, I think, of the chronic disease story because obesity is the driver of these other diseases. But what accounts for that? What explains the rise in the prevalence of obesity across the entire population? It's not that the entire population decided to become or to develop obesity at that point. Something changed, and I don't think we know what changed. But interestingly enough, the same phenomenon existed worldwide. So it's important to see this as a population problem, not as necessarily an individual behavioral problem, which is what has stigmatized people with obesity, is the perception that it's a failure on their part of nutrition and physical activity. The costs are substantial. The cost of obesity alone to businesses are about $450 billion a year. And the cost of obesity alone in terms of the GDP is about 7%. Now, my candidate for what began to drive obesity rates in 1975 is ultra-processed foods, which are ubiquitous. And what's not to like about them? They're high in fat, salt, and sugar. They're almost addictive. They're inexpensive, widely available, and have an extraordinarily long shelf life. And those are the foods that are relied upon by particularly low-income populations, which helps account for the disparities because obesity is much more prevalent in Black populations and in Mexican American populations. So I think how we begin to address that is really important. And I'm looking forward to this discussion about food as medicine. But I would remind you that food is medicine and things like medically tailored meals are at the top of the pyramid. And the reason that these therapeutic interventions work in that group is because we failed to prevent the kind of diseases that they're being treated for in adulthood by focusing earlier in childhood.
You have these two ways of using food to achieve better health outcomes. Food as medicine, or these individualized, medically tailored food solutions, are top of the pyramid solutions, right? But healthier food, better nutrition overall, can almost prevent some of those diseases that you're then treating with the individualized health. Where do we focus first? Is it important to go to that top of the funnel and really lean in there to solve those individualized problems? Or as a society, should we really be addressing nutrition first? Where do you think this plays out?
We have a mosaic approach that we take at S2G, and I think we should focus on both. I think Bill makes a very good point. And we certainly should be focusing on some of the precursors that might lead to negative human health outcomes at scale for populations. And part of that starts when we're young, and part of that starts with habits. Part of it starts with access to affordable nutrition. And we certainly need to be leaning into solutions that provide that access to affordable nutrition and education. And we need to continue to learn more about what makes us healthier over time. At the same time, we have a large population that is already dealing with diseases of inflammation, and we need to address those problems as well.
Yeah.
And so I think we have to touch every point in the pyramid. But over time, if we really want to make a lasting change, I do think it starts with that foundational approach to how we feed ourselves as a population at the population level.
Susan also spoke about the importance of focusing on those population-level interventions, especially earlier in life.
I do some work for NASA, right? So we're trying to figure out how to get the astronauts to Mars, and they have to regrow their foods. And we think about calories. And I know that as a practitioner, when we deal with the cancer patients, you got to have protein, you got to have calories. We don't think about nourishment. But yet, when we think about the astronauts, that is the only thing that we're thinking about is how can we nourish them, get them to Mars and back? And there is tremendous opportunity for us to think about that in the school lunch programs, in the WIC programs, in the food deserts that we have. And again, people feel very comfortable with foods. And it's something that actually can reach mass populations. And people, governments, communities are definitely open to that.
Are you seeing in the medical community, because one of the stats we have is less than 1% of training relates to nutrition. I've heard it's like a half day, a video or something on nutrition that an aspiring doctor gets. Is there awareness, acceptance, use of nutrition as a tool at scale, or how are you seeing that landscape today?
We definitely have significant room for improvement there. But the mindset is starting to come in. So even though I think I got a half an hour of nutrition, maybe in medical school, orthopedic surgery resident, I got zero discussion about nutrition. Why do I know much about nutrition as much as I know? It's from dealing with patients with obesity and having to help them through fracture recovery. And it's from dealing with the cancer patients where we do have to focus on nutrition. Even if I want to send a patient to a nutritionist, it's almost impossible to get an appointment, no matter what community I've lived in. And I'm on my third different community for practicing. It's very difficult to get access to a nutritionist. But there are a lot of community groups that work together that are trying to solve some of the food access problems. And as physicians and primary care and specialists, understanding how we have to help and play a role in that is opening people's minds to it, plus the science. That will make the huge difference with the providers as to what foods, how, what combination, what are we trying to solve for. Even if it's the 4 kilograms of blueberries not the answer, we know the bacteria on the back end
in your gut biome that helps to modulate the signaling for osteoarthritis, right? So then how do we target that in a way that's accessible, affordable, and acceptable?
I think there's an important distinction to make between nutrition and food. Nutrition is the reason that I think it's not taught in medical schools is it's cross-cutting. So you get calcium metabolism when you talk about orthopedics, or you talk about breastfeeding for infants, or you talk about iron and hemoglobin in hematology. And those are nutrients. But I think when you have a conversation about food, it's a much different conversation, that people are more likely to resonate with it because they understand it, whereas nutrition is confusing because messages contradict each other. So I think that changing that conversation is an important step forward to change the general perspective.
I would agree. And I go back to that nourish, right? We all want to nourish our patients. So trying to get us to come back to that holistic view of the patient, which almost every physician has, but we tend to treat to the test. And there is some change that's happening there, even in the medical community, even in conversations, of the fact that things have gotten so complex that we actually have to look at systems and teach systems. But that's an emerging way for us to think about this in medicine.
Yeah, I read in 1985, the National Academy of Science suggested all medical students get 20 hours of nutrition education. A recent survey said of the top medical schools, they're getting 11 hours on average. Better than a half hour, but it's moving in the right direction. But I think it's incumbent on industry then to fill the gap and be a source of genuine education, not schlocky, go in with a sales sheet and try and promote your product with a little bit of science on it, but to go and be a reliable source of education. And then if you have made a better product, the education will help the physician understand the use of that product. Another challenge I also read, this is from the AMA, is that if a physician themselves do not practice a healthy diet or lifestyle, they are highly unlikely to make recommendations to their patients. So there's a little bit of doctor heal thyself that is required if we're going to rely only on the medical community to be our source of education for families, patients.
One thing I found just fascinating and somewhat terrifying is the conversation that Susan Bukata raised on the panel around how much nutrition education doctors get during their residencies and training, and it's quite limited. So when it comes to nutrition, where does that responsibility really lie in the issue of education failing? And where would it be most effective? Is it the doctors? Is it tech companies? Is it the education system? Is it the product providers? Curious your thoughts on how we make progress there.
I think the optimal state of the world is yes to all of those constituencies. I think ideally, because all of them play some role in the way that a person establishes their habits with respect to nutrition and in the way that they treat disease and any ailments that they're dealing with. And so I do think it would be ideal for the doctor to have more education with respect to nutrition. As a person who didn't go to medical school, I don't want to be critical because I know they get a lot of other very critical
education. It's already
education.
a long process.
Exactly. But I think that would be phenomenal. One of the things we are seeing is parts of the medical community leaning into and acknowledging the import of an understanding of nutrition and its impact on health. That's positive. There's a green shoot there. But ultimately, it's the responsibility of the individual to the extent they have actual access to nutrition. And so it's a multifaceted problem. Education is a critical component of it, but it's only one component.
Panelists mentioned that having the science and the data to back these nutrition-based health solutions would help with adoption by healthcare providers as well as patients. But high-quality nutrition data is notoriously difficult to gather because of the timeline needed to assess impacts and the countless variables that contribute to human health outcomes.
I wonder, you've mentioned the data, meeting the other community where they are. How much data are we talking about? Is it clinical study? Are these smaller trials? Is it pointing to other research?
Yeah, I have an opinion, but I'm not sure that the nutrition world needs to do pharma quality research. yes, do clinical investigation, but on a smaller scale. There are plenty of cases now where there are points of data, maybe related to a specific procedure, where nutrition is shown to help the outcome. We're in a movement now. I think of this points of data like pixels on a screen. The more pixels you have, the easier it is to see the overall picture of the value of nutrition as part of healthcare routine. So we're moving toward more data points, more research that will help, again, partly educate the medical community, but help them really appreciate nutrition as a tool in their toolbox to help take care of their patients.
One of the challenges in this space is really gathering the data to get the basis of information to sway the healthcare community to really adopt these solutions at scale. What do you think are the different research standards that need to be looked into, and how much data do we really need to move these things forward?
I think it depends on the product, the indication, and really the use case. Certainly believe that in certain scenarios, meeting the healthcare community where it is today, meaning providing that similar or that same level of data and proof of efficacy, is very powerful, because there are certain scenarios where you want your trusted advisor, your doctor, to be recommending something or to steer you in the right direction. And those might be in the more acute type care situations, or they might be about specific indications more so than a general approach to maintenance of an optimal diet. But I do think there are scenarios where meeting the community where it is today with that similar level of data is important. I think there are other scenarios where I don't think we do need to have the same level of clinical study to understand the impact of certain food decisions and decisions with respect to nutrition. And so in those cases, I don't think we need to go as far, but I really do think it depends on the scenario.
To wrap up the conversation, Matt asked the panelists to peek into their crystal balls and share a positive prediction or any positive outlooks they have about the future of the food as health sector.
It feels like some degree of optimism here from the three of you about at least openness to things changing for the better. Perhaps if we can wrap up with a future state that you'd like to see or that you think is coming.
I'm totally excited by today, protein, carbohydrate, fat, fiber, they're relatively blunt tools to use in terms of a nutritional toolbox. But tearing apart protein and realizing that there are parts of it that have bioactive components, we're at that point. Like Shiru is here. They're doing amazing research to figure out what bioactives are in common proteins. And other companies are working on carbohydrates, and there's work on fats. So we're getting smarter about how to utilize nutrition. And it's not eating a basket of blueberries. It's extracting the part from it that really makes a difference. And with those bioactives, using nutrition as a co-therapy along with drugs, I think there's a great future there. Maybe you can even extend a patent on a drug. You can get better efficacy from a drug. Maybe there's a drug that failed its final clinical by this much. And if it was paired with the proper nutrition, you can now get over that threshold and genuinely help more people. Maybe oncology, chemotherapy can be less toxic because you can make it more effective, need less of it, and help patients recover faster. So I'll stop there, but there's probably 100 more things I could say.
I'm not going to answer your question, but because I had a broader takeaway from my experience here. And one of the striking things to me here is the optimism and positivity that you all have around change. And in a university environment, my experience is different. So for example, I taught a class a couple of weeks ago, and I've begun using this tool that I call the Hope Despair Scale, which is a Likert tool, 5 points for hope, 5 points for despair. I asked students where they stood on this Likert scale, on the Hope Despair Scale. Most of the students were at 1. But 3 or 4 were on the negative side, -2, -3. And I think unless we begin to think about how to engage students and Generation Z in these kinds of changes and the kinds of changes that you're so enthusiastic about, we're going to fail. So I would urge you to think about how we encourage and support this generation, which so recognizes the importance of climate change and is frazzled and often hopeless about how they can make a difference.
I think I can back up a little bit of both of that, right? It's how do we look at that growth mindset instead of a fixed mindset, right? We tend to get pessimistic in a fixed mindset. We can only take care of this versus seeing all the incredible opportunity in front of us. And particularly as we get better at the science, being able to connect the two together in physicians, in students, and we're training STEM and all of these things in our students. They're learning some of this in freshman biology class in high school that's going to stick with them for a lifetime. So how do we get to that level and then build up on that? And there's so much great knowledge that's coming out, but it's how we communicate it into population health. And it's thinking about it. Osteoporosis is a population health problem. Osteoarthritis is a population health problem, but we tend to think about it as the metal I'm putting in your knees or the fracture I'm fixing. And the patients don't even think about it that way. It's how we have this conversation about health as a population. And COVID actually helped us to open the door. Almost everybody in the country knows what public health is now. But in our young population, that's where we're going to change it. How do we get them thinking about that and having that growth mindset?
The panelists talked a lot about the fact that many diseases, a lot of which are severely impacting a lot of the population, such as obesity, osteoporosis, are real public health problems, not just individual health problems. How does that framing really impact how you approach this from an investment perspective?
So we look at the space from both an individual and population level. So we look at both frames. As it relates to the individual, we see that there are certain foodstuffs or food ingredients that can drive a particular and specific human health outcome for specific individuals that might need that outcome. And we're invested in the companies and technologies that are either identifying what those specific things are or bringing them to market. And this is where let food be thy medicine. Some of this it's individualized. And the things that you eat or a different approach to medications that might be food-based that can drive specific health outcomes are for the individual. But obviously, our nutrition as a population impacts our health as a population, and we're also looking at it through that lens and investing in the technologies and solutions and companies that are helping to bring more affordable nutrition to the masses. And that should have an impact on our cost of healthcare and on human health at scale.
At the end of the panel, there were a few more minutes for Q&A. One of the questions asked was around personalized nutrition and whether the panelists see that movement in conflict with the idea of population health.
I think there's a huge gap between personalized medicine and practice. For example, we know that people with type 2 diabetes, that 50% stop taking their medication. And that to me is an illustrative of the fact that even if you have a significant disease, you don't necessarily follow the kind of directions that for taking care of yourself. And I'm a skeptic about personalized medicine, and that the same thing, that people may know what they need but will not use it for one reason or another, is likely to happen. And part of that, I think, has to do with access. And my guess is that around the issue of personalized medicine, it's going to resonate much more with upper income families and people rather than underserved communities, which are already stressed and have low access to the kind of resources or income that they're going to need to be able to follow personalized medicine. We can't even get people to increase their fruit and vegetable intake. So how can we get them to change the whole pattern of their eating that would be necessary for personalized medicine and personalized nutrition?
So I'm going to devil's advocate that a little bit, right? And it goes back to my mother is a statistical risk mathematician who repeatedly tells me I present my papers upside down, right? 99.999% good, that 0.0001 bad, right? People see themselves as the zebra.
That's the personalized medicine. They're like, I'm not in the herd of horses that's all around me. I'm the zebra. Something bad's going to happen to me. And that's a mindset thing more than everything. Whereas where we've had great achievements in healthcare, it's been in population health. It's helping the herd understand their symbiosis with each other. And we, especially in the US, we live in a very individualized, people are very proud of their individual identity and achievement. So they're not always thinking in that herd mentality. Look, vaccines, right? Getting people to be thinking a little bit of this is good for everybody. If I can say one thing about Gen Z, they are good at looking at things that way. They are peer related, and whether they will age out of that or not. But this is an opportunity for us to continue to build upon that with that generation and thinking global community and getting people to realize I'm not the zebra. That's great, right? You don't want to be the zebra. You want to be comfortably taken care of in the herd of horses.
Another question was raised about the important levers to overcome some of the barriers that were discussed throughout the conversation.
I might say it's collaboration, because compliance, it was mentioned earlier, compliance is the biggest challenge. And the collaboration I'm talking about is from a government policy perspective, it's from the medical community perspective, and from industry working together to help people utilize the tools that we can give them. And this is your bioactives. Cambrooke bought a company called New Ultra in the UK and Ireland, and they worked with the National Health Service there to create a family of nutrition products, very dense in nutrition, very low in calorie, to help people with diabetes lose weight. And when they lost weight, the idea was their diabetes would go into remission. The NHS paid for the product. They also hired nutritionists to help the patients. They also hired social workers effectively to help them with the overall concept. And after 13 weeks, 85% of the participants had lost 10 kilograms of weight, and 2/3 of them found their diabetes in remission. Any single effort from one of those three groups would not have been successful. It was the collaboration that made it successful, because compliance, even with drugs, is a big challenge. So I think that's where we, the three representing our parts, can do best, as we get together and come up with a program that helps people stay the path.
I asked Matt what he thought about Howard's response that collaboration was maybe the most consequential lever, particularly when it comes to moving the needle on regulation and compliance.
It's a great point about the importance of regulation and how it might evolve to perhaps, to a greater extent, consider the impact of nutrition on human health outcomes. And I think that an adjacent point is the extent to which the healthcare system can provide support for affordable nutrition.
Yeah.
And as we see that suboptimal nutrition really does have a significant cost to the healthcare system and to all of us because of that cost, I think there is incentive for participants within the healthcare system to, in the future, to a greater extent, bear some of the cost associated with providing greater nutrition. I think at the population level and the base of the pyramid, there is significant potential for impact there, because the more that we can provide access to affordable nutrition to the masses, the more that we can start to tackle some of those population level health challenges that we see in the market today.
I think this came up on our last podcast too, right? What is the healthcare system's incentive to lean into these solutions when their payment models may not be completely aligned to that now? It's certainly something to watch and consider.
And part of the incentive is cost to the system.
Yeah.
And if there are things that we can point to that say that this will actually lower this cost over time, this has this impact on inflammation.
Yep.
And patients with this lower level of inflammation have lower incidence of this costly negative healthcare outcome. And we can drive inflammation down by this less costly food intervention. Then we start to see the right incentives and maybe models that will work. And we're excited and believe that we will see some of those in the future.
It's interesting. Sanjeev talked at the beginning about it's not just innovation, it's business model innovation as well. So tying it back to that. You asked the panelists what future do they hope for, You didn't get a chance to share your hope for the future, so would love to hear what future state are you really hopeful for as this progresses forward?
I'd like to see, and I think that we will see in the coming decade and beyond, a food system and a healthcare system that have converged to a greater extent. And we know more about the specific impacts of specific foodstuffs, ingredients, and habits on our human health. And we can optimize. And I think that is going to allow for a sizable opportunity to create better human health outcomes, but also economic opportunity in doing so. I also think that we're going to see the healthcare system perhaps playing a greater role in bringing nutrition to its membership.
Yeah.
And that means optimization at that level in the channel as well. And I think helping create that optimization is also a very large economic opportunity.
We are out of time. Thank you all so much. And thank the panelists here for joining us.
Thank you for tuning in to the S2G podcast. If you enjoyed this episode, please subscribe, leave us a review, or share it with a friend. For more information or to connect with us, check out s2gventures.com.